Hello, everyone, and welcome. On behalf of the MedDRA MSSO and the Uppsala Monitoring Centre, it's my great pleasure to welcome you to this year's global webcast. Wherever you're joining us from around the world, we're absolutely delighted to have you with us today. My name is Jane Knight, and I'm a clinical associate with the MedDRA MSSO based in the UK.
Good afternoon, Jane, or it feels more like evening, so dark here. Hello, everyone. I'm Soe Yoon. I'm a product specialist here at the UMC, and indeed, we are very thrilled to have you here today. And it is my pleasure to co-host today's event with you, Jane.
Thank you, Sohei. So throughout 2025, both the MSSO and the UMC have held user group meetings in various locations around the world, and some of you may have joined us at those meetings. We've had the pleasure of seeing some outstanding user presentations this year. So, as we approach the end of the year, we've invited several of those speakers to repeat their presentations, which we've recorded to share with you today in this session. We'll begin with opening remarks from the directors of the UMC and the MSSO, followed by update presentations from both organisations. After that, we'll move into two MedDRA user presentations and two WHODrug user presentations. So firstly, from the MedDRA user group meeting in China held in May, we have a presentation by Elaine Jiang from Pfizer. Later, we'll also hear from Evelyn Bassani and Natalia Menezes from Bayer, who presented the Latin America user group meeting in Brazil just this September. And so, hey, please tell us about the presentations that you've brought along for us today.
Of course, and thank you, Jane, for the introduction. From the WHODrug side, we're excited to share today two brilliant presentations. The first comes from our WHODrug user group meeting in Poland that was held in April this year. It's delivered by Emanuele Calabro from KC. We are also delighted to feature Jill Frady from Moderna, who presented at the US user group meeting in June. You can find more details about their sessions in the agenda. And we've prepared material handouts for you, which can be found under the Resources tab in Zoom. You can also download the slides from respective organization homepages from UMC, the WHODrug user area, or for MedDRA, the MSSO events page. Please note that all attendees will be on mute throughout the webinar. If you encounter any audio issues, take a moment to perform a sound check within Zoom. There will be short Q&A sessions following the joint director's presentation, as well as the MSSO and UMC's presentations, and from our user presentations, Moderna's and Bayer's presentations. For these sessions, you can use Slido, which is accessible via the event QR code or by visiting Slido's website and entering Global Webcast as the joining code. However, due to time zone differences, there will be no live Q&A sessions for the remaining presentations. If you have any questions for those speakers, you're most welcome to email them directly. Their email addresses will be available on their respective presentation slides. Please note we are recording this session, and the recording will be available on the UMC and MSSO websites and on our respective YouTube channels.
Thank you, Sohei. And also something new is that thanks to the new webinar platform this year, we're able to provide you with live captions in the language of your choice. So to activate this, just click on the show captions icon. If you have a look at the bottom bar on your screen, and this is in your meeting controls toolbar down at the bottom. And then lastly, at the end of the webinar, you'll be prompted to complete a brief survey. And your feedback, it really is invaluable. It helps us to improve for next year's event. So we truly appreciate you taking a few moments to share your thoughts with us today.
And with this, we would like to officially open the broadcast with a few words from our organization's directors. We'll start by introducing our director. Peter Hjelmström is the director and CEO of the Uppsala Monitoring Center, which is the World Health Organization and Collaboration Center for the Program of International Drug Monitoring. He's a physician with an MD and PhD from the Karolinska Institutet, and he did his postdoctoral fellowship at Yale University. Prior to joining UMC in 2023, he spent 17 years in the pharmaceutical industry, most recently as Chief Medical Officer.
And so also then let me introduce our director. Patrick Ravel is the director of the MedDRA Maintenance and Support Services Organisation, or MSSO. Patrick is responsible for the maintenance, delivery and support services for MedDRA around the world. Patrick reports to the MedDRA Steering Committee, which has representatives from the industry and the regulatory authorities in Japan, Europe, United States, and some other regulatory regions, as well as the WHO. Patrick's been with the MedDRA MSSO project since its inception in November 1998. So let's hear from them.
Good day, good morning, and good evening. My name is Peter Hjelmström, Director of Uppsala Monitoring Center. It is my pleasure to welcome you to this WHODrug and MedDRA Global Webcast event on behalf of both Uppsala Monitoring Center and on behalf of the MedDRA Maintenance and Support Services Organization, MedDRA MSSO, and the International Council for Harmonization of Technical Requirements for Pharmaceuticals for Human Use, ICH. First of all, I would like to thank all of you who have attended any of the in-person face-to-face MedDRA WHODrug user group meetings during the year, and in particular to all of you speakers and others who have contributed to these meetings. Also, thanks to all of you who have attended any of our webinars, webcasts, and online trainings during the past year. We have, during the past year, seen an increase not only in the number of attendees, but also in your engagement in creating the user community so vibrant in learning from and sharing your experiences. For us at UMC and MedDRA MSSO, your engagement in the user community is invaluable in helping us to serve you better and in order to develop our technical solutions for you. Both the MedDRA and UMC drug dictionary WHODrug are vital medical terminologies, providing standardization for secure exchange and global use of pharmacovigilance data. Our vision is safer use of human health products, in particular medicines and vaccines. And having standardized data is becoming increasingly important in today's world. We are therefore very grateful in seeing both the user community becoming more and more international, with new users and increasing engagement from countries, for instance, in Latin America and Caribbean, and in the African continent. But we also see continued strong engagement from long-standing users in countries and regions such as United States of America, China, and Europe. Finally, before handing over to Patrick Ravel from MedDRA MSSO, I would like to thank both the staff at Uppsala Monitoring Center and MedDRA MSSO who have during the year worked together with you for another excellent year of collaboration. I hope we can strengthen this collaboration even further in the year to come with you in the user community for patient safety. Thank you very much, and looking forward to this webcast.
Thank you, Peter, and thank you for attending the 2025 Global UMC MSSO webcast. My name is Patrick Ravel, and I'm the director of the MedDRA MSSO. The MSSO maintains, distributes, and supports MedDRA on behalf of the International Council for Harmonization, or ICH. As Peter mentioned about our collaboration, it is one that the MSSO values a great deal. Our work together has been beneficial to both organizations and to our user communities. It's a very natural collaboration since we support the same users and have the same goal to contribute to the safe use of medicines globally. I'd like to mention that we are close to a decade of WHODrug MedDRA connected and or co-hosted user group events. Beyond our user group meetings, We have also worked successfully together in 2025 to provide WHODrug and MedDRA training for new users in Latin America and Africa. In that context, we just completed a combined MedDRA WHODrug training for South African industry users to discuss getting started with both terminologies, coding with both terminologies, and performing analyses with both terminologies. We're adding a new combined user group meeting in the Middle East and Africa in Cairo, Egypt in the fall of 2026. More details to come about that particular meeting. We're planning a combined WHODrug MedDRA training course in conjunction with the EU user group meetings in April 2026 in the UK. Our goal is to continue these collaborative efforts into 2026 and certainly beyond. Peter and I hope you find this best of event to be useful, and we encourage your questions throughout the webcast.
So thank you, Peter and Patrick, for these lovely opening remarks. And we're very fortunate to have Patrick joining us live today. So if you have any questions for him, please send them in via Slido and I'll read them out. So just give you a moment to send your questions in there. And Pat, it was good to hear you mention the South Africa collaboration with the UMC and the WHODrug. I was involved in this one, so it's one that is particularly important to me, and it was great to see such positive feedback from the users at this. So just, as I mentioned, just while we're waiting for any...
It's a nice evolution, I think, of our training, so, and maybe a logical next step, so I'm glad we did that. Yeah. And thanks for the effort. Yeah.
As you say, we're doing it again this next year coming, so let's see. So any questions from our audience for Pat or anything for Peter that we can pass on afterwards? No. Well, I'm not seeing anything, Pat, so maybe they'll come in after
that's
the
fine.
MSSO update.
Just happy to join, so. Yeah.
If you do have any questions, send them through on the Slido or via email to the MSSO help desk, and we'll forward them on to Pat afterwards if you haven't had a chance to think of it right on the spot. Thank you, Pat. Thank you for your update and your presentation.
Thanks, Jane. And so, hey.
Thank you, Pat. And I think for, at least in the morning, we've had some questions to Peter come in very last minute, and we were able to address them at the next session. So yes, we can approach it that way. Thank you so much for your presentation, Pat. And it is now time for our next presentation. And yes, allow me to walk you through the latest UMC updates. And I will be addressing any questions at the end. So please submit them to Slido if you have any. Hello again. As you know, I am Soya Yoon from the Uppsala Monitoring Center, and today I will be presenting you with the report from UMC. Before I move on, here's a quick outline of my talking points today. I will first fill you in on some regulatory updates regarding WHODrug and the global standardization initiatives UMC is a part of. And then I will share a selection of recent and upcoming improvements for WHODrug Global. Lastly, I will round off with updates about our support, events, comms, and training. And on to our first topic, regulatory updates and global standardization initiatives. On this slide, you can see a selection of several countries that have announced that they will mandate the use of WHODrug Global, primarily for the C3 format. If you're interested, you can find more details in the references linked on this slide. And please note that there might have been changes to the official statement since this slide was compiled. So we always advise you to look at the regulatory updates web pages as the primary source for most up-to-date information. In March this year, the US FDA released a new version of their data standards catalog, and in this version, they reorganized the columns and information. WHODrug Global is now referred to as UMCDD, which stands for UMC Drug Dictionary. There are no practical changes to the regulatory expectations. And now there are references on the UMC web which states that the UMC drug dictionary equals WHODrug Global. Many of you might already know about ISO-IDMP, but let me start with a quick introduction for those of you who are not familiar. IDMP stands for Identification of Medicinal Products. It is a set of 5 ISO standards that were released in 2012 and describe how to standardize information and create identifiers for the medicinal product, the pharmaceutical product, as well as the substance used in the product, the pharmaceutical dose form with units of presentation and the route of administration, as well as strength and the units of measurement. Implementing the ISO-IDMP standards globally would facilitate the unique identification of medicinal products in the context of pharmacovigilance and the safety of medications throughout the world, both in communication between people as well as in IT systems. The main focus for UMC regarding the ISO standards are the global PHPID, an identifier for the pharmaceutical product, representing information on the substance, the dose form, and the strength of a medicinal product. The C3 format of WHODrug mirrors the foundations of IDMP and could be a mean for moving towards the use of IDMP in the future. As to how we can apply the PHPID in reality, of course, identification of medicinal products is a vital component in all stages of a medicinal product's life cycle. I will discuss use cases in a few specific areas to begin with. So product shortages is a major concern for regulators globally, and especially if a country or regions cannot solve the shortage with a replacement product already that is approved within the country or the region. An example of such case would be the shortage of the ingredient cisplatin that was with the strength 1 milligram per milliliter and a dose form solution for injection that happened in the US a few years ago. This is, of course, an oversimplification of the scenario, but regulators would have an easier way of identifying what product to import in case of a shortage in a PHPID implemented world. When every approved medicinal product is linked to a global PHPID that is unique to the pharmaceutical product. So with this example, with ingredient cisplatin strength of 1 milligram per milliliter and the dose form in solution for injection, the PHPID becomes the medicinal product's common denominator from country to country, regardless of where it is produced, prescribed, dispensed, or used. So we also see the possibility of PHPIDs implemented in dispensing systems to identify pharmaceuticals. Norway has come forward with a use case there. And EMA is exploring how PHPIDs could facilitate cross-border healthcare within the EU, specifically within the scope of prescribing and dispensing medicines across borders. And of course, for pharmacovigilance, the goal is to be able to utilize PHPIDs when reporting ADRs to national regulatory authorities. So then what is the role of UMC in global ISO-IDMP implementation? UMC is actively promoting ISO-IDMP and collaborating with many stakeholders to make IDMP implementation a reality. And at the same time, we are working hard to finalize systems and processes to provide global pharmaceutical identifiers and global substance identifiers in 2026 by linking them to existing WHODrug products. So, and of course, as the provider of WHODrug Global, we will continue to develop the dictionary for our users, but with the added benefits of IDMP integration. Then how will ISO-IDMP information be incorporated into WHODrug? Currently, we have a lot of data already within the B3 and C3 formats of WHODrug, and each format has a unique WHODrug identifier. On top of this, we are adding IDMP data. So global PHPIDs will be mapped to C3M PIDs to match its granularity. And along with PHPIDs, WHODrug will also be including the input parameters that were used to create the global PHPIDs. If you'd like to learn more about IDMP, please check out the UMC training that is now publicly available to everyone on the UMC website. You can also access it by clicking on the link provided on the slide. Our next topic is recent and upcoming improvements in WHODrug. We continuously work to improve our WHODrug offerings to our users, so there have been many updates, but consider this as a highlight reel, if you will. So I will start off with something that is technically last year's news, but good news bears repeating, I believe. So here it is. Since June 2024, all WHODrug Global users have access to WHODrug Coda as part of their license or part of their subscription. For those of you who are unfamiliar with WHODrug Coda is a UMC custom-built coding service that is designed to enhance the efficiency, consistency, and quality of drug coding. To address common questions from our WHODrug users related to WHODrug Coda, we have added a frequently asked questions sections to the WHODrug user area. So be sure to check it out. If you have any lingering questions, you are, of course, feel welcome to contact us. And if you want to learn more about WHODrug Coda in more detail, we recommend watching the WHODrug extended webinar from this year in April that is dedicated to WHODrug Coda. Next are changes to our web browser Insight. It is our most beloved tool, so we are always looking into ways to improve your experience with Insight. And this year we saw several changes to WHODrug Insight, out of which I would like to highlight the following: the up-versioning of WHODrug CDGs, improvements to the C3 format browsing, and implementation of some of the 2026 changes in upcoming data. So firstly, CDG up-versioning. New functionality has been released in March of this year, and it supports the up-versioning of CDGs. Before, up-versioning was a manual process, but now we provide a service to automate this process. So how does it work? WHODrug CDGs are up-versioned one by one, and this is performed by rerunning the CDG inclusion criteria in the new version of WHODrug Global. Changes between the versions are listed and presented for the user to review, and user can accept or reject the proposed changes. WHODrug CDGs are organized by versions in the CDG library with updated CDG history, and up-versioning reports are saved and linked to the CDG history for reference. So nothing's better than the real thing, so let's take a look at how it looks via this video. So there it is. Hopefully this will make maintaining your CDGs so much more easier. The next update in Insight I'd like to draw attention to is the transition between the drug search and MPID search tabs in Insight when browsing C3 data. This was implemented for September this year, I believe. So before in drug search, if a user wanted to look at C3 specific data, such as our C3 format MPIDs, the user had to engage with a tiny pop-up via the C3 detail view button. But now when hovering over the train name, a clear C3 detail button appears, which leads to a smooth transition into the MPID search tab displaying the same C3 information as the C3 pop-up. If needed, the user can transition back into the drug search tab to find the previous search result, still active. Users can, of course, continue their browsing in the MPID search tab without coming back to the drug search tab, or continue their search in the drug search tab, depending on the task at hand. Lastly, I'd like to showcase some updates we have been making to insights that are visible when you work with the WHODrug upcoming data. Over the past year or two, I've been talking very extensively about some changes to WHODrug content we have planned for 2026. If you are not familiar with these changes, please find the document that covers all the changes in detail linked to the image of the upcoming changes document here on the slide. I strongly advise you to take a look, as I will not have time to cover them all here in this presentation. But going back to Insight, the core concepts that will be renamed in 2026 are reflected already in upcoming data in the product type filters, as you can see. Column headers are also updated, and the newly introduced substance synonym is also available as a column for selection. The changes to the old form, so the renaming to archive record and the removal of the flag in the name specifier field in Insight and also in the files, is also visible in this upcoming data view. The renamed archived record designation can be found in the country of sales column like it was before for old form, but has been renamed to archive record. Upcoming data in MPID search tab is also fitted with the renaming, as you can see, MPID to record ID or RID, and old form to archived record. You can see that the search filters and the column headers are updated to reflect these new names. Another update to the MPID search tab in upcoming data is the new archive record search filter. This filter is activated only when another search term is entered in another search filter. For example, here I have put in input for country, and that is why the archive record filter has been activated. And if you click on the archive record filter after it has been activated, you can apply different search filters. So for all records, regardless of the archive status, or you can search for, you can see search results that exclude the archive status records, or choose to look at only the archive status records. So all of these changes that I have gone over that are only available in the upcoming data will also be live in the 2026 March version of WHODrug in Insight next year. And just a reminder, you can always find the most updated release information in the release history that pops up every time there has been a new update released to Insight. The release history can be later found in the top right corner of Insight in the drop-down menu under the username if you would like to revisit it again. My final point, support, events, communication, and training regarding WHODrug. If you have attended our webinars before, perhaps you've noticed an update to our monthly webinars. We now have divided the webinars into two different series. The Essential series that targets newcomers and beginners to WHODrug and will cover core WHODrug concepts. These webinars will also be provided in multiple languages, as you can see, English, Chinese, Spanish, Portuguese, Korean, and Japanese. And our extended series, which focus on WHODrug news and guest speakers, targeting our more intermediate and advanced level WHODrug users. These will be held in English only, but will have the caption function available to support our multilingual WHODrug user community. Also, an always up-to-date program for all our webinars is available in the WHODrug user area, and this is both applicable to the Essentials and Extended Series webinars. And I don't know if you've noticed, but our communication strategy for all WHODrug events has been also updated. We now send out a WHODrug events newsletter that includes all upcoming events for the next few months. This email covers webinars and WHODrug user group meetings in a single email where you can see an overview of all upcoming WHODrug events. We typically send this newsletter in the middle of each month, so remember to keep an eye out for this email. If you're using either WHODrug Insight or WHODrug Coda, I'd like to direct you to our 4 new training videos on the UMC web, which provide a step-by-step guidance on how to use these applications. And at present, these are only available in English, but we hope to be able to support more languages soon. Looking forward, these are future improvements we have planned for WHODrug. UMC is developing a certification program for WHODrug users to be launched next year. This will not focus on the more in-depth practices, like, for example, the coding policies, with the target instead being to show the proficiency or the knowledge of WHODrug based on the UMC training material and the core concepts of WHODrug. Upon completion, you will be able to receive a digital certificate that can be shared if required. We are also working to provide easier access to WHODrug information on the UMC website. We want to have more information available with easier access to reach out to a wider audience. Work has already begun with a finish date expected at the beginning of 2026. And finally, UMC is updating its communication with the introduction of targeted information emails to all new WHODrug users. We want to be able to make sure that our new users receive information that is the most relevant to them. So we will be updating how we reach out to our new users. A reminder before I finish off how to stay up to date on WHODrug news. Every year in March, we release the What's New in WHODrug in PDF, containing a summary of sorts of all the changes that happened in the previous year between the previous year's March release and this year's March release. And as the WHODrug user, you can also receive the WHODrug newsletter that we send out quarterly, always updated with new information about WHODrug. And finally, twice a year, we have a What's New in WHODrug webinars timed with the new releases of the dictionary. If you want to know more, please look into these sources directly for more detailed information and to keep up to date with recent changes in WHODrug. And finally, join us for our user group meetings. They're held all around the world. Here are the locations and dates if they have been already decided for 2026. So I hope we have a chance to meet all of you face to face next year. And that's it from me. Thank you so much for your attention. And if you have any questions, I will be happy to address them via Slido. So I hope you enjoyed the presentation, and please, if you have any questions about my presentation or maybe WHODrug in general, send them in to Slido. You can go directly to Slido and use the invitation code Global Webcast or scan the QR code here displayed on the screen to be directed to the correct Slido poll or Q&A. I can address maybe something ahead of the questions coming in. A popular question from the morning session was more information about the certification program. The amount of information I have shared is the amount I am able to disclose at this moment. So please just keep a lookout for any updates. I do not have any more information that I can share, unfortunately, as of now. I think we have one question that has come in. Let's see. Yes. I would like to know the use of having drug names with old forms in WHODrug. Oh, this is an excellent question. So it starts from why WHODrug was created in the first place. It was created to standardize drug information in ADR reports. And unfortunately for ADR reports, they come in for drugs that are already taken off the market. People have old drug cabinets with too old medications. So there was a need to actually still capture information about outdated drugs. So that is why we have this. We know that there are users that use the old from flag as when they're coding legacy data as well. So for PV purposes, primarily, we keep all the drug data that it was added into WHODrug if we know it was correct. If it has been removed from the market or is no longer current, for the lack of a better word, we have started making use of the archive record, the new name for the old farm flag, and designating it as an archive record. But that is why we generally do not delete data unless it was blatantly incorrect. Yes, thank you for this question. I think we have another question about CDG upversioning. Let's see. When upversioning CDGs, can you select the version of the dictionary, or are you only able to upversion to the most current version? So as of now, because this function is quite new, we have only introduced upversioning to the most recent version. So if there is a new version out, you should be able to upversion to that most recent version. We have not, let's say, fully developed the capacity to support other versions. But if this is something that you need or would like to have in the upversioning tool, please let us know so we can prioritize what your most burning desires are, so we can prioritize what kind of developments and support we can provide to our WHODrug users. But I will take note of this, that this was a question. I'm guessing it is because you're interested in this function. But please reach out to us and let us know. Approach us at user group meetings and such, so we know that this is something that you would like support for. Thank you for the question. For the preferred and preferred code, should the column labels also be updated to substance and substance code respectively? I'm guessing it's talking about the preferred names and the preferred name drug codes. And the column labels, I assume, are referring to internal databases or UIs of programs, because for Insight, they have already been updated to substance in upcoming data. But yes, we strongly urge you to align with the vocabulary that we use to avoid confusion. The preferred name or the preferred record will be referred to as the substance record moving forward. So it is best if you can align with the names and labelings that we use at UMC to avoid confusion and maintain consistency. Thank you for a great question. Yes, we have a question about the C3 format. Thank you, Sohei. Would there be any changes in the pipeline regarding the C3 bulk chain request template? Sorry, maybe the possibility of this template matching Insight download file. Also including a status add update archive might be helpful to all parties. Yes, I believe this was something that we have seen as a request, and this is one of the many project developments that we are hoping to get around to as we try to better improve how we have input data. We can't promise anything as of now, but it is on our list of things to do, which I have to be honest is very long. But we are looking into this, and we have heard that it would be a great use for those who work with C3 format and the change requests. So thank you for bringing this to our attention. Again, giving us loud feedback really helps us prioritize. Thank you, Don. How can I request including the specific names for a drug substance which isn't in this dictionary? So for substance names, I think we are very particular about what names we use. When available, we use INN names. If not, we take other generic, more commonly recognized names based on like Yusan, Jan, etc. So if it is a commonly recognized generic name, please submit it as a change request or a dictionary modification. I think it's possible to make a dictionary modification request in our change request tool. Doesn't matter what kind of request it is, but please send it in and we will review it. If it is a lab code for an investigational drug, we do also add those with sufficient references. So if it is pertaining to that kind of situation, you're also most welcome to make a change request. And our substance specialist will review and add it to the dictionary based on the reference. Great questions we are having today. I think we have a question about substance records. So the preferred records, yes. Will the substance records be only in English or will you consider any other different languages? So currently, substance names in WHODrug, we have it in English in WHODrug Global. We have WHODrug Global Chinese, which is an entire dictionary in Chinese. So you can have the substances in Chinese there. We do provide Portuguese, like Brazilian Portuguese to be exact, and Spanish translations of substances, which are available as additional feature files in the WHODrug package in the C3 format. I think they should technically be available in the B3 format as well, but definitely in the C3 format. And also you can choose to display these substance translations in the Insight browser as well. If you select the WHODrug version, there's also a drop-down menu below the version menu to select if you want to see the Portuguese or Spanish translations for substances. Currently, that is all of the languages we support for substance records, but again, we try to support user needs when there is a greater user need. So if you feel like we're missing a language that is being used and very in high demand, please let us know and we will review and try to find the experts that can provide that kind of substance information in that language and have it available to our users. But yes, please let us know what language it is and what use case you have for these substance translations, and we will look into it. Thank you for the question. I think we're getting very specific questions now. For nutraceutical products, we normally see multiple ingredients in the generic name field. Some have multi-minerals and multivitamins. Can they be standardized with a shorter generic name so that they can be used in systems where there are length restrictions? First of all, I would like to clarify, I am not a substance matter expert on this. So the content, we have a separate content team. We have terminology specialists who deal with the specific content that goes into WHODrug. So I cannot say yes or no to this request here on the spot, but my 2 cents would be we're very careful about adding umbrella records because if you have multiple versions meaning the same thing, it takes away from the harmonization and consistency. So I don't know if it would be possible to add another record that would mean virtually the same thing. Maybe if it means a subset of multi-minerals and multivitamins, maybe that would be something that they can consider. But please, if you have a need for this, submit the change request so our subject matter experts can review this request and make the most best decision based on their expertise. But this is a very interesting question. Thank you. And I think I will perhaps address this one last question before we move on. What is the benefit of a certification as a WHODrug user? Well, it is, I guess, with all certifications, proof of that you have a certain amount of knowledge in WHODrug, which could benefit you in certain situations where you have to prove your experience or knowledge with WHODrug. But it is basically, I guess, based on requests that we've had from our WHODrug users to have some kind of certification program. So it's to prove that you have a basic level of understanding based on the kind of training and education that we provide. So it would prove that you have taken part in our courses and trainings. I think that would be on the surface of it, what you could make use of the certification that we're providing from next year. Great. That's all we had time for. But if you have any remaining questions, please feel free to send them in to the WHODrug support email. And thank you so much, everybody, for engaging. Over to you, Jane.
Thank you very much, Sohei. So the next presentation today is the MedDRA update report, and this is delivered by Brian O'Hare. Brian serves as the Terminology Maintenance Manager responsible for the MedDRA change request process, the biannual MedDRA release, MedDRA translations, and provides guidance and oversight to the MSSO's IT projects. He's earned a bachelor's degree in English and Public Relations from James Madison University and a master's degree in Information Systems from George Mason University. So Brian has recorded his presentation, which we will now play, but he's also here with us live and is happy to answer any questions you may have at the end. So again, as we've been saying, put them in Slido and we'll read them out to Brian at the end. So let's hear what he's got to say.
Well, thank you. I'm pleased to provide the report of the MSSO for this global webcast. The topics I'd like to cover today are the 2026 MedDRA subscription rates, the MedDRA tools that we've deployed in 2025. I'll talk about where we are with our supported languages in MedDRA, and the latest addition to our training program, the Learning Management System, after which I'll take your questions. So with respect to the MedDRA subscription rates for 2026, there will be no increase in those rates over what they are today in 2025. One of the things to note about the MedDRA subscription rates is that they either have been reduced or have stayed the same since 2005. That's 21 years. It's not something you can say about a lot of products these days. And the reason we're able to do that is that the MedDRA subscription base continues to grow. And this allows us to spread the cost of maintaining and supporting MedDRA over a larger set of organizations, allowing us to keep the rates the same or reduce them. I'd like to now talk about some of the MedDRA tools that we've deployed in 2025. In particular, I wanted to focus on the browsing tools that we have. As many of you know, we have 3 different options to browse and search MedDRA. We have our web-based browser, our MedDRA desktop browser, and we have a web-based mobile browser that is useful for smaller platforms such as smartphones and tablets. Now, specifically, we made updates to our web-based and desktop browser. And the motivation for this change was based on the utilization data that we had from our web-based browser, which showed that the search function is used by 99% of the time by MedDRA users. And all the other functions that we have in our web-based browser, such as the SMQ analysis and the hierarchy analysis function, only account for 1% of that utilization. So based on this information, we determined we had to make a change in our platforms to focus on what users are doing. And at the end of the last year, we launched our new web-based browser. And the main change to this browser is the user interface to provide a simpler look and optimize the interface for what 99% of MedDRA users are doing, which is searching and displaying of search results. Now, in addition to that, we have done some additional features. We have incorporated the MedDRA version analysis function. We've also provided mapping information and term details, and made it easier to submit translation update requests. In sum, all of the functions in our legacy browser are built into our new web-based browser. They're just in a different location. And here's a screenshot of what the user interface looks like. So you can see it's very streamlined. And for those of you that are using our legacy web-based browser, this is a bit different, but it also should be very familiar in that the browsing is on the left and the search and displaying the search results are on the right. So transitioning to this new tool should be fairly straightforward. With respect to our MedDRA desktop browser, we did deploy a new version of this tool, and this was updated to match the interface changes we made in the new web-based browser. So in other words, a simpler look and optimizing the tool for searching and displaying of search results. One of the things that I wanted to note about the desktop browser is, of course, it does not require internet access. And for those of organizations that utilize our web-based browser, they may want to consider the desktop browser as a backup option for business continuity purposes, based on all of these global outages that we've had recently affecting web-based applications and internet providers. Here's a screenshot of the desktop browser interface, and you can see it's very similar to the web-based tool. So the transition between the two platforms should be very straightforward. Let me switch gears and talk about the MedDRA APIs, or Application Program Interfaces. For those less familiar, APIs are a way to provide an interface to other pieces of software. And they are used by software developers building web-based tools to provide features and functions for the things that they want to do. And in the case of the MedDRA APIs, this is being able to display MedDRA terms and codes in a variety of different ways. Now, the MSSO provides a wide variety of API functions, and I'm listing them here on the screen so you can see what they are. Specifically, we've added a new functionality called the Download API. And what the Download API does is it gives MedDRA users, or more specifically software developers and database administrators, an additional streamlined option to obtain the MedDRA data files and incorporate them into their pharmacovigilance systems. This is in addition to the method of providing the MedDRA files through a zip file download on the download section of the MedDRA website. Now, we're going to continue to produce those zip files, so that's not going to go away, but the Download API just gives users an additional option to obtain the MedDRA data files. And by the MedDRA data files, what I mean is the files such as the LLT file, the PT file, the MD-Hire file, etc. These files are available in all languages and versions through the Download API. In addition to that, we're providing 3 mapping files in the latest versions, which is the ICD-10 to MedDRA mapping and the 2 bidirectional SNOMED CT mappings. The MedDRA files are provided in 2 different formats for users to choose from. The first is the $ delimited format, which is very familiar to those of you that have been working with the MedDRA files. This is the traditional format that we've always provided MedDRA in. And the other format is one that's very common with APIs called JSON or JavaScript object notation. So you have your choice between those 2 formats. Now, before I switch gears, I wanted to talk about MedDRA and artificial intelligence. I think we all know that AI is rapidly evolving and transforming our lives, both on a personal as well as professional level, including drug safety. Now, most of your organizations by now have or are actively exploring ways to leverage artificial intelligence to gain efficiency and accuracy within the processes that you currently have. And MedDRA coding, of course, is no exception to that. The industry is actively exploring AI-driven enhancements. Now, the MSSO is currently considering how best to utilize AI both for our internal purposes, such as terminology maintenance, the area that I'm responsible for, as well as applying AI for the direct benefit of MedDRA users. And at this time, I cannot provide specific details on what we're considering. I do want to emphasize that AI is a key focus for the MSSO, and that we hope to announce our specific plans in the near future and how you can benefit from them. So now let me transition to our supported languages. I think most of you are aware that we provide MedDRA not just in English, but in a variety of different languages to facilitate coding throughout the world. We're presently up to 27 languages, 3 of which we added this year. I'm showing those languages in the middle column of the slide. And we're also working on 5 languages presently, and we hope to deploy 4 of those languages in 2026. Most of the European languages that we've been added recently are being added to support the European Union's Electronic Prescribing Information Initiative. One of the big focuses we have with our supported languages is quality. We put a lot of effort into trying to ensure that we have the best quality possible in all the languages that we support, but there's always room for improvement. And this is why the MSSO supports requests from you, the MedDRA user community, to propose updates to the translation of terms in all the languages that we support, provide a more accurate translation. Now, any MedDRA user can do this through our WebCR tool by supplying their MedDRA ID and subscription password. And there's no limit on the number of translation update requests that you can submit. So if you are working in another language and you identify terms that are not as optimally translated as you think they should be, you're more than welcome to submit a translation update request to us to have that reviewed. So the last topic I'd like to talk about is our learning management system, the new addition to our training program. So as part of your MedDRA subscription, you have a number of options to pursue with respect to MedDRA training. And we provide 3 kind of categories of learning to accommodate how you prefer to learn. The first is our in-person training, which is great for new users because it provides hands-on exercises and gives you direct communication with an instructor. We also have the live webinar training, which is best for refreshing of knowledge on MedDRA, and it typically focuses on more advanced topics. And then the third option we have is on-demand e-learning. This is also great for refreshing of knowledge, but it's also good for users that prefer self-paced learning. And this is where we've added a new component to our training program called the Learning Management System, or LMS. We launched this platform in January of this year, and presently we have over 1,600 users making use of this option. And what the LMS does is it provides a platform to host the MedDRA training videos, but provides those training videos in a controlled and monitored environment for self-paced learning. And it offers multiple levels designed in a specific learning path, where when you complete a specific element of training or a module of training, you get what's called a completion certificate. Now, specifically, the learning management system is divided up into 2 different tracks. Both tracks contain the same content. The first is called the certificate track, and this is where you have to take the learning path in a very specific order. So you can't skip around, and you have to take specific quizzes at various inflection points. But when you complete a track, when you complete a module, you get what's called a certificate of completion, which I'm showing on the left side of the screen. The non-certificate track contains the same information, but it allows you to skip around and take these elements of learning in any order that you want to. This is great for refresher training. If you do complete a module within the non-certificate track, you do get what's called a well done badge, which I'm showing on the right side of the screen. We're offering these training videos within the LMS in 6 languages presently, and we're going to be adding Portuguese, which we expect to have on or before the second quarter of 2026. So that concludes my presentation. I thank you for your attention, and I welcome any questions that you might have. Please enter those in the Slido application.
Thank you very much, Brian. Great to hear there all what's been happening this year. We do have one question that's come in, so let's just bring that one up on the screen. Are there any plans for the MSSO to expand the LMS into more topics?
That's a good question. Well, Jane, you might have some more awareness than I do, but at least to the best of my knowledge, there aren't any specific plans at this time for additional topics. I think the focus at the moment is to make sure that we have all of the supported languages, or those languages that I showed, rather the six languages, well supported in the learning management system.
Yes, that's right, Brian. We started with the points to consider document and we picked out what we thought were the key points that warranted articulate LMS videocasts, and that's where we've got to. But I would put it back over to whoever it was of you that asked the question or anyone else out there. If you notice that you think there are gaps and there are topics that you'd like videos, then please let us know and it's something we can look at. I wouldn't say that we would never, that we have had a few ideas around, but when, as Brian says, we're not actively working on any at the moment, but we have got some in the back of our head that we're going to look at next year. So any requests you've got, please send them in to us and we can put those on the table for consideration along with the ideas we've got. We had another question this morning, Brian, just whilst we're getting the other questions in, that that somebody asked how many users can an organization have and to use the LMS. If they've got one subscription, how many users can use it?
Well, the good news there is that there is just an unlimited number of registrations that you can have per company. So there's no limit on how many people can register for and use the learning management system within your organization.
Yeah, it's great to hear. It's good news, isn't it? So if we have had another question just popped in, Brian, changing theme now, would it be possible to include the SMQ file on the MSSO website along with the other version documents?
Okay, that's a great question. Well, let's see. I think the issue with that would be is, as you know, MedDRA is offered on a subscription basis. And while we do want to share some of the documents, the SMQ file is, intellectual property, and it's only available to subscribing organizations. And for that reason, that file, along with the MedDRA files, are just reserved for MedDRA users, and that's why we don't put those in the public area of the MedDRA website.
Thank you, Brian. And one more here we've got here. Oh, they're coming in quite a few now. So let's move these across to you. Back to training now. What's the difference between the certificate of completion and the certificate that requires an exam?
Let's see. I think, Jane, you can maybe assist me here. I think the certification that requires an exam is referring to the Certified MedDRA Coder program.
Yes, I think so too.
Okay. Well, the CMC, or the program, Certified MedDRA Coder program, is very focused, as is the MedDRA training, on the points to consider document. The difference is there is, the exam is a specific quiz on the content of the PTC, and the training videos that we have are focused kind of more in general approaches to coding. And Jane, if I have not provided the best answer, go ahead and fill in the gaps there.
That's good, Brian. Yes. So that's perfect. If we haven't answered your question, please come back to us on any of these. Another one now. We've got one it relates back to LMS that I'll just move it across. That says, I have a number of my team that I'd like to have an LMS account. Is there a quick way for them to sign up? I don't know. Do you want to deal with this one,
Let me
Brian?
take a stab at that. I think maybe our help desk can assist with that. I think there's a way for us to apply a larger number of users rather than have each individual sign up for their own account. So if you want to contact our help desk, or maybe Jane, we could get this individual's contact information, we can work with them to assist with that.
Yes, absolutely, Brian. If you email us to the help desk, we can do a bulk upload, as you say. So I'm just looking down to see if there are any other training related ones. I thought there was another one about certificates, but I can't seem to see it now. Anyway, let's keep going. Changing topic again now, Brian. one here that relates to what you told us about the upcoming combined Middle East and Africa meeting in 2026. Do we have any more information that we can share with our users today about?
So, yeah, I don't have a lot of details on that. It will be in October, I believe 11th of October. Don't quote me on that. Is the date for the MedDRA user group meeting. And then I think the training will follow that. And I don't know if it follows immediately after, but it's certainly within that week. So that the week of the 11th of October, I believe, is when that training is scheduled.
That's great. Good. A lot of information there, Brian. Thank you for that one. Back now to the question. We've got the inquirers come back to us further to the previous question about the S&Q file. Could the subscription area facilitate downloading this as a separate file rather than having to download all the dictionary files? So I think a bit of clarification there
Okay.
for the
Well,
S&Q
that's something, yeah,
spreadsheet.
that's something we can consider. We do so to clarify for everyone, the SMQ spreadsheet file is part of the zip file package that I alluded to when I talked about the download API, and that file is contained within the zip file rather as a separate posting. So certainly, it's something we can consider.
Thank you, Brian. And then the last question we have here is, I think we can generalize it a bit. It relates to new translations and how new translations come about. The specific question I'm just putting on the screen now is, have you ever received suggestions or requests for translating MedDRA into other languages like, and I'm sorry, I can't say it, Quet, you can see it, you can pronounce it. I think there were concerns about this during the pandemic in Latin America.
Mhm.
Um,
Well, we do occasionally receive requests for new languages, and typically the way that works is that the local regulatory authority makes a request to the ICH, the intellectual property owner for MedDRA, for a new language, and they have to provide some justification for why they need an additional translation of MedDRA. And the MedDRA, the ICH considers that and just determines whether to approve that or not. So at a high level, that's how that happens. So if you are interested in another language, you can certainly submit a request to our help desk. But likely, what'll need to happen to move forward with a language or to make a decision on a language is there'll have to be an official request from a local regulatory authority for a language.
Thank you, Brian. Thank you. Well, we've covered all those questions. I see we've got a couple of minutes left. So this is your last call. A couple of minutes there. If anyone's got any further questions for Brian, anything that he's presented, or maybe something more general, MedDRA in general, now's your chance.
I think perhaps one of the questions I can't answer because we've gotten this before in the earlier session is regarding the transition period to the new web-based browser. So as most of you know, we have our legacy web-based browser, which many of you have been using for many years, and we have a new web-based browser. And so we get oftentimes the question asked, well, when are you going to run a legacy web-based browser? So we do retire it at some point. At this time, I don't have a specific timetable to share, but rest assured we will give users at least 6 months notice and make sure that we alert as many people as possible through our communication channels, so broadcast, email, social media, etc., about when we're going to be retiring the legacy web-based browser. But to give a general time frame, it's probably not going to happen before the second half of next year. Sometime in that period is probably when that'll occur. And it may even be later than that, but we will give people plenty of notice when we retire our legacy tool.
Thank you, Brian. That's good to know. Thank you. Well, no, I haven't got any more questions for you at this time. So final call. Anybody typing? No, I don't think so. So thank you very much, Brian, for your update and for your very lively Q&A session. So thank you.
Thank you.
If you do have a reminder, if anyone has any further questions, you can contact us at any time via the MSSO help desk, or we have an online chat pop up on our website. And if you address your questions to Brian specifically, anything that he's presented, we'll pass them on to him. So thank you, Brian. Enjoy the rest of your day.
Thank you.
I'll hand back to you then, Sohei.
Thank you, Jane, and thank you, Brian, for such an informative session. And thank you again to our audience for engaging so lively. Up next is our first user presentation from Emanuele Calabro, who is a Principal Data Manager at Casey. Just a quick introduction of Emanuele. Emanuele holds a Master of Science in Biostatistics and is a data management expert with over 14 years of experience in the pharmaceutical sector. He is an active member of professional organizations, including the Society for Clinical Data Management, a CDM. At Casey, he is involved in regulatory submission activities, including those to the Chinese Medicines Approval Authority, NMPA, and the Pharmaceuticals and Medical Devices Agency, PMDA, in Japan. His presentation is on navigating data submissions, the role of WHODrug Global Chinese. And now on to the presentation.
Good morning, good afternoon, good evening, everyone. It's a pleasure to be here with you at WHODrug and MedDRA Global Webcast. Today, I invite you to join me on a journey through the evolving landscape of data submission, where language, technology, and regulatory science come together. Let's discover together how the WHODrug Global and MedDRA Chinese edition is opening a new possibility for global collaboration and regulatory success. Before beginning, I'd like to share a brief disclaimer. The view and the opinion expressed in this presentation are my own and do not necessarily reflect the official position of UMC or CDISC. I also confirm that there are no conflict of interest to report. Okay, let me briefly introduce to the agenda. I'll start with a slide about Chiesi, who we are. Then I'll set the scene and move to the regulatory package, explaining what it is. Next, I discuss the use of dictionary in the clinical data package. And finally, I'll conclude by summarizing our experience as Walls Wins Wisdom. A few words of Chiesi, who we are. Chiesi is an international biopharmaceutical group certified as a B Corp with a 90 years of experience. In 2024, more than 24% of sales invested in R&D. And we are proud to be the first pharmaceutical company in Italy and among the top 15 in Europe. Okay, now let's go to the topic by setting the scene. Let's start with an overview on our drug development process. After approval in Europe and other countries like Australia, in the last years there was a case expansion into Chinese market. We designed specific studies for the Chinese population, including both pharmacokinetics on healthy volunteers and pivotal trials. By applying the Chinese clinical technical requirements, we ensured that our development strategy was fully aligned with the local regulatory expectation. A couple of words of a Chinese national authority. The main authority is NMPA, National Medical Products Administration, and there are 3 affiliated institutions: Center for Drug Evaluation, National Institute for Food and Drug Control, and Center for Food and Drug Inspection. This slide shows the general procedure and timelines for NDA submission in China. As you can see, the process involves several key steps, from package validation and supplemental documents to technical and administrative review, QA rounds, Q&A rounds, and clinical trial inspections. Each phase has its own timeline, and the overall duration can vary depending on the complexity of the submission and the time needed to address regulatory questions. Careful planning and timely responses are essential to navigate this process efficiently. Now let's talk about the regulatory package. The regulatory package was composed of ECTD clinical module on European population because in this experience, as I said before, the drug was already approved in Europe. To meet Chinese requirements, we added the clinical study reports from Chinese studies, additional documents on clinical development in China, and the clinical data package. Before our NDA submission in 2023, four key guidelines were released in China. The China GCP, provision for drug registration, technical guidelines on data management, and the guideline on the submission of clinical trial data. Since our submission took place in 2023, we needed to apply all these guidelines, with particular attention to the guideline on the submission of clinical trial data. For completeness of the timelines, I'm pleased to share that we obtained the approval in 2024. So now let's talk about the guideline on the submission of clinical trial data. As I said, it was released in 2020, and this guideline is primarily applicable to pivotal clinical trials for the purpose of drug registration. And it includes information about the study analysis database, data reviewers guide, annotated CRF, and the most important for this presentation, foreign language database. If we open this page of the guideline, we clearly see that for a study database, at least the following content should be in Chinese: dataset label and variable label, adverse event terms, generic name of concomitant medication, and medical history. So our study, our package was built in English according to our standard. Then we needed to apply a strategy for the translation in Chinese. And then now we can see how the dictionary in the clinical data package helped with this goal. Let's start talking about the clinical data package. It is composed of databases in standard CDISC, SDTM, ADAM, annotated CRF with SDTM annotation, programming code, data definition file, a data reviewers file, a data reviewers guide. As you can see from the asterisks, except the programming code, all other items needed to be translated in Chinese. In this presentation, we will talk about the SDTM annotated CRF and database. Starting from annotated CRF, the NPA requirements needed a PDF format and the translation for a question designed to collect data and value or code list of efficacy indication. So we used as basis the original CRF version we had in English to translate the blank CRF in Chinese. Then for the annotation, we used as basis the one we prepared during the study in English, and with the use of the Chinese version of SDTM implementation guideline, we translated the annotation in Chinese. And then you can see an example of the ECRF page of the concomitant medication. On the left, the original one in English, and then on the right, the translated in Chinese used for the submission. Now let's move on database translation. In this step, we address the translation of database elements to meet MPA requirements. All dataset and variable labels, as well as the key medical terms, must be translated into Chinese to ensure traceability and regulatory compliance. Sponsor is encouraged to submit data in SDTM ADAM, meeting traceability, analysis ready, and analysis metadata. Concerning datasets and variable labels, our strategy for translating them involves creating an Excel file with all terms, ensuring they conform to the Chinese version of SDTM ADAM implementation guidelines. Such programming is used to update the datasets with the translated text, and double programming is applied to guarantee correctness. This systematic approach helps maintain consistency and data quality throughout the submission. Before mentioning our strategy to translate the concomitant medication, let's talk about the WHODrug Global Chinese Edition. It plays a crucial role in our submission strategy. By providing standardized drug information and ATC classification in Chinese, it enables accurate translation and coding of medication data. Regulatory updates and alignment with the Latin character version ensure consistency and reliability, making it essential for a source for regulatory submission in China. Our strategy to translate the concomitant medication using the Chinese version of WHODrug includes 3 steps. Let's start with the first step, in which we focus on the translation of the all unique terms for prior concomitant medication from English to Chinese. Each term was listed in an Excel file, translated in a separate column, and then programmatically updated in the dataset using SAS. Independent double programming was applied to ensure accuracy. In this second step, we focus on the translation of coded terms using the WHODrug Global Chinese Edition. For each medication, all key coding variables such as generic name, ITC classification, and coded term are programmatically translated into Chinese, ensuring consistency with the English version. This approach not only meets regulatory requirements, but also supports clear communication and traceability through the submission process. So, by leveraging the Chinese edition of WHODrug Global, we can streamline data integration and facilitate regulatory review in China. The final step in our translation workflow is the consistency check. Here, we verified that all coding terms matched between the English and Chinese datasets, using unique term codes as identifier. If a Chinese translation was not available for a specific term, the English version was retained. This process ensured data integrity and reliable traceability, which are essential for regulatory compliance. Here you can see the example, the real screenshot for the SDTM concomitant medication dataset. The first table, the original one used during the study in English, and then the second one, the translation in Chinese used for the submission. When preparing the SDTM concomitant medication dataset for submission in China, we encountered some technical challenges. The length of the variable field, since the Chinese character weighs more than in the English one, the need for UTF-8 encoding for Chinese characters. Another challenge includes the alignment between English and Chinese dictionary, since during the study we used the 2018 version and the first Chinese version was released only at 2020. Our strategy was, whenever a Chinese term was enabled, the English term was retained. The steps were essential to guarantee both regulatory compliance and data integrity throughout the submission process. For the adverse event and medical history, we adopted the same strategy as for concomitant medication. All unique verbatim terms were translated into Chinese using the corresponding version of MedDRA dictionary. Coding variables were updated programmatically, ensuring consistency and accuracy between the English and the Chinese datasets. This approach not only fulfills regulatory requirements, but also supports data quality and traceability throughout the submission process. And here the screenshot of the data sets. The first one, the screenshot for the data set used during the study, and then the translated in Chinese using for submission. Okay, we arrived at the conclusion. As I mentioned at the beginning, I'd like to conclude my sharing, my presentation, sharing three key reflections from our experience, what I call the walls, the wins, and the wisdom. First, the walls. These represent the main challenge we faced, such as evolving Chinese regulatory requirements, the complexity of the translation beyond simple language conversion, applying Chinese version of both SDTM and ADAM implementation guidelines, and ensure that all datasets and documents were fully aligned. Navigating these barriers required both technical expertise and adaptability. Next, the wins. Despite the obstacles, we achieved important successes. Our strong internal know-how in FDA submission helped us in data package preparation. The use of Chinese dictionary to streamline the translation, a validated translation, and the close collaboration between teams all contributed to a smooth and compliant submission process. And finally, the wisdoms. Looking back, planning ahead and establishing internal standards for Chinese data submission proved essential. We also learned the value of leveraging Chinese dictionary from the very beginning, and perhaps most importantly, we hope that in the future regulatory requirements will become even more harmonized internationally, reducing the need for extensive translation. Before ending, let me thank the rest of the submission team, Rebecca, Principal Statistical Programmer, and Glauco, the Disease Area Statistical Lead. Thank you so much.
It seems like my video is down again, but I hope you enjoyed Emmanuel's informative presentation, his invaluable insights from his experience of leveraging WHODrug Global and WHODrug Global Chinese for successful submissions to NMPA will be highly beneficial, I'm sure, for organizations navigating the Chinese regulatory requirements and aiming for efficient and accurate data submissions. We have a live Q&A with us because Manuel is available with us today. We're very lucky to have him address any questions. So if you have any questions, please submit them via Slido. And while we are waiting for participants or our audiences to type away, I will sort of start off by asking you a question, Emmanuel. I guess it would be more of a reiteration of what you have emphasized in the conclusion of your slides. You've shared the walls and the wisdoms, but what was the sort of highest wall that case you sort of had to scale, what was the most challenging in your preparation for the NMPA submission, and what would be your recommendation for others who are embarking on this challenge to lessen the burden, to learn from your experience?
Hey, thank you for the question. So the biggest challenge for us was the translation in Chinese, because we are a European company. We have colleagues that supported us for the translation in Chinese, and then yes, we needed to find some way to make the translation of the database and the terms in Chinese in a validated way that could meet regulatory requirements. So likely the data package submission is very similar to the one to be submitted to other regulatories like FDA or PMDA. Here, the challenge was some part of this package needed to be translated in Chinese, and we didn't have standards for Chinese. So my suggestion and what we are trying to apply also within my company is to start elaborate some process, some SOP that could help in speed up this process of translation.
Thank you for your insights. I'm pretty sure it would be very helpful for those that have to address the Chinese language. It's a barrier, because if you don't have you're not used to working in a different language, and that's not the data set that you originally have, it is a challenge, right? I also have another question from a WHODrug perspective. You've obviously leveraged the dictionaries where they were available, both for MedDRA and WHODrug, but there were parts that you had to translate without dictionaries. How do you think your process would have worked if you didn't have these dictionaries available?
So no, yes, it was a good question, since at the beginning, when we started to think about a strategy, was everything was putting in a desk. So without the Chinese version of MedDRA and WHODrug, it would be more difficult to apply this to meet the regulatory requirements, because these dictionaries are validated. So these helped us a lot in this translation in terms of quality, but also to meet timelines. Without this Chinese version, we needed to provide a process to translate with an official translator to guarantee that the translation meet the requirements and are identical to the English one, and so on. So we would take time, but additional resources like people and economic resources. So using the Chinese version really helped us in meeting regulatory requirements.
That's great to hear as a provider of one of the dictionaries. I think actually maybe your presentation was crystal clear. We do not seem to have any questions coming in. So, but if any of our audience has a burning question afterwards, Emanuele shared his email in the presentation, so please email them directly to him, or you can reach out to us and we will make sure these questions are shared with him. And thank you so much, Emanuele, again, for the very informative presentation and being here live with us to answer questions. We really appreciate it.
Thank you. Thank you so much.
Thank you, and have a nice day. So thank you, everybody, for kicking off this event so wonderfully. We can take a short break now. Please grab a cup of coffee, and we'll see you in about 10 minutes.
So, welcome back, everyone, to the MedDRA and WHODrug Global Webcast. It's now time to hear more about the evaluation of MedDRA coding in adverse events for individual case safety reports, or ICSRs, from Pfizer Medical Director Elaine Jiang. Elaine Jiang is a physician with over 14 years of experience in pharmacovigilance, bringing extensive expertise in the medical evaluation of ICSRs. So let's watch her presentation.
Good morning, good afternoon, and good evening. My name is Elaine Zhang, Medical Reviewer from Drug Safety Department of Pfizer. Thank you for the invitation from MedDRA User Group Meeting. It is my honor to share the topic, MedDRA coding of adverse events in ICSR evaluation. The presentation represents only the individual viewpoints. For practices, please consult advice from relevant departments within your organization. There are 3 parts in my presentation. The first part is an overview of the MedDRA guidance documents. The second part is case sharing on considerations during MedDRA coding adverse events in some specific scenarios. The third part is about how to request the MedDRA coding changes. Now let's begin with the general principles and the MedDRA points to consider in event trend selection. I'd like to use a metaphor to describe the process of MedDRA coding of adverse events. I thought of Lego bricks. We all know that bricks used to build a house need to be uniform in shape and size. The initial VT information we receive is scattered irregular Lego pieces, different shapes and size. Through a unified standard, we cut and shape them into standardized Lego bricks, categorize them and use them to build a fortress for drug safety, enabling safety alerts and risk management. The process of coding adverse events is like the MedDRA engineer you see in the picture, carefully crafting each foundational brick according to the MedDRA standards to build a drug safety fortress. There are 10 key points in the guiding document, MedDRA 10 selection points to consider covering quality requirements, principles for LLT selection, medical judgment during coding, hierarchical structure to reviewing and ensuring we neither omit or add information during coding process. In the PTC and the companion documents, various scenarios and good coding practices are detailed, which give us a clear reference for similar cases. It also outlines what to consider during coding, such as diagnosis or symptoms, definitive or provisional diagnosis, demographic descriptor like age, gender, anatomic location, type of microbial infection, congenital or acquired condition, and so on. We also consider whether to combine and slip terms. When coding medication errors, we should consider who was involved, was it intentional or unintentional? Was it for a therapeutic purpose? The last but not least, seriousness assessment is particularly important and worth emphasizing. For ICSR, the reporting timelines depend on the seriousness judgment. If a serious event is incorrectly coded to a non-serious MedDRA, it becomes a compliance issue. Next, let's look at several scenarios of MedDRA coding examples. These are based on Pfizer internal coding principles and also adhere to MedDRA's guidelines. The first scenario is about precise expression of medical concepts. The LLT we select must accurately reflect the medical concept event experienced by the patient. A core body temperature equal to or above 41.5 degrees centigrade can be defined as hyperexia, while fever or pyrexia is a broader term. If a reporter reports fever temperature 38 degrees centigrade, we can code it as fever or pyrexia, which is mostly a non-serious event. However, if the reporter states fever, temperature 41.5 degrees centigrade, it should be coded as hyperpyrexia. Hyperpyrexia is a serious adverse event, but fever or pyrexia in this case would not fully reflect the severity. This example follows PTC section General Gen Selection Principles 2.4, always select a LLT that accurately reflects the reported verbatim information should be selected. In this case, inappropriate coding could lead to miss an SAE report. This is very important. Next example, if the reported information is blood pressure value shown as 170/100 millimeters of mercury, should we code it blood pressure reading high or hypertension? By checking the hierarchy, SOC of blood pressure reading high is investigations, while hypertension falls under vascular disease. Hypertension as a disease has specific diagnostic criteria. Seated office blood pressure equal to or above 140/90 millimeters mercury on 3 separate occasions without antihypertensive medication. And ACCHA guideline recommends a lower threshold. So, if only a single elevated measurement is reported, it doesn't meet the diagnostic criteria of hypertension. The accurate coding would be blood pressure reading high. This example illustrates that reviewing the hierarchy helps determine whether to code a diagnosis or an investigation, so that to ensure the meaning of the reported term accurately captured. This aligns with the requirements in PTC section 2.9, checked hierarchy, and 3.14 investigations, selecting terms for a medical condition versus an investigation result. Here is another interesting example. If patient A experienced an adverse event following sexual contact with B, a male who had used the drug, what would be the event coding? Transmission of drug via semen, exposure via semen, or exposure via partner? Drug exposure isn't necessary through semen. It could be via other body fluids or blood. Therefore, exposure via partner is more appropriate. In this case, we should code the associated adverse event as well, and this also follows the requirement of section 2.4 of PT document. For scenario medical and surgical procedures, according to the PTC document, terms in SOC surgical and medical procedures are generally not appropriate for AEs. If a procedure is reported, select term for the procedure. In some cases, for MedDRA coding, there can be preferred and alternative options. If both the procedure and the diagnosis reason are reported, the preferred option is to code both, since coding the procedure can indicate the severity of the condition. For example, appendectomy for appendicitis can be coded as both appendicitis and appendectomy, indicating that the appendicitis was severe enough to require an operation. However, in ICSR reporting, we may also choose the alternative option, code only the reason and report it as a medical diagnosis, such as coding only appendicitis, and capture the detailed surgical treatment in other sections of safety database. This is also okay, but regardless of the approach, the PTC requires consistency within the organization and documentation in internal coding guidelines. When choosing the alternative option, if the procedure is performed for a unique medical diagnosis, we can code the diagnosis directly. However, if the reason is uncertain, it is advisable to code the specific procedure, provide the internal principle. For example, cataract surgery is performed uniquely for cataracts, so we can directly code cataract. But Cardiac surgery is too general, which may not be solely due to cardiac disorder, so it is better to code the procedure only. In such cases, we should follow up to obtain the exact reason for the procedure and further recode the event based on follow-up information. Next scenario is about antineoplastic therapy. If a patient experiences progression, aggravation, or recurrence of the existing cancer, should we code it as drug-infective? Generally, drug-infective or lack of drug effect means no improvement in the condition after administration of the therapeutic drug. Regarding change in therapeutic effect, the relevant PTC chapter states that the preferred option is to select only the term drug-infective. The alternative is to code drug-infective plus the condition, the indication of the drug. For example, in the PTC case, the patient took drug for headache, and the headache didn't go away. The preferred option is to code only drug-infective. The alternative option is to code drug-infective plus headache. But for oncology products, should we follow this guide directly or need additional considerations? For this question, our company's internal rules are cautious. Unlike other drugs, antineoplastic drugs require distinct coding rules due to the specificity. It is often not aimed at curing the disease, but at prolonging overall survival or alleviating symptoms. Moreover, progression, aggravation, and recurrence of cancer are expected per its malignant nature. Equating cancer progressive, aggravation, or recurrence with drug-infective is not always appropriate. Therefore, drug-infective requires more rigorous scientific judgment and objective medical evidence, such as pharmacological support. For example, no cytopenia after myelosuppressive therapy. Hence, in this example, we'd better to choose the LLT that reflects the progression, aggravation, recurrence of the existing malignant neoplasm. Please be noted that the actual LLT is not listed in the table under the LLT heading, which is different from the other examples in my presentation. We can find more guidance on modification of effect in section 3.23 of PTC document. The second topic is second primary malignancy. Second primary malignancy is not the same as secondary malignancy. It is not recurrence of metastasis of the existing cancer. It is a different cancer from the first primary malignancy and may arise in the same organ as the primary malignancy or in a different organ. When new cancer is reported in a patient receiving an antineoplastic drug, LLT, second primary malignancy, should be coded per Pfizer policy. For example, if a patient develops malignant melanoma after receiving a drug for breast cancer, in addition to malignant melanoma, we should add the LLT, second primary malignancy. In this case, by slipping coding, we use an additional term to reflect the nature of the event, which is very important supplementary information. The final scenario about product quality issue complaint. I will share with you how we code it in ICSR for your reference. When processing report with product quality issue and complaint, select the term that appropriately reflects the product quality issue complaint. If the quality issue is confirmed in quality investigation result, maintain the original specific product quality issue term and add an additional code product quality issue. For example, if the initial information reports color of the drug changed, we code product dislocation. After follow-up is received with quality investigation confirming the issue, we add LLT, product quality issue. If there is no available appropriate term to indicate the specific product quality issue, the default LLT is product complaint. If the quality issue is confirmed in quality investigation result and there is still no suitable term, change the LLT from product complaint to product quality issue. For example, we received a report for event desiccant breakage or fragmentation for which there was no available appropriate term indicating the issue. We coded it as product complaint. In this situation, please remember to submit a change request to MSSO. Regarding product quality issues, you can find more guidance from PTC document section 3.28. Based on the user request, the MSSO has already added relevant term product desiccant damaged in the latest version 28.1. Now we can code this LLT for our case. This leads us to our final topic, update and maintenance of MedDRA coding. MedDRA coding is not static, and the governance of ICH MedDRA Steering Committee, MedDRA is continuously enhanced to meet the evolving needs of its users worldwide. PTC Section 2.6 mentions, do not address deficiencies in MedDRA with organization-specific solutions. If there is no MedDRA term available to adequately reflect the reported information, submit a change request to MSSO. We can submit a request via the relevant link on the MedDRA website, and now we are also allowed to submit requests directly through the latest new web browser. Finally, how can we make the coding both efficient and accurate? Here is the summary. Record truthfully means coding unreported information stay faithful to the facts. Guide by guidelines means using MedDRA guidance documents as the framework. This brings clarity and confidence. Search multidimensionally means trying both top-down and bottom-up searches, a dual-channel approach. Build on medical knowledge means strengthening your theoretical medical understanding. Only with a clear mind can we ensure precision. Standardized documentation. Establishing internal standard coding process help improve both quality and efficiency. Adapt culturally, accounting for Eastern and Western cultural differences, enable unified standards for global collaborative defense. Maintain collectively. The maintenance of MedDRA requires our joint efforts as users, ensuring it remains up to date and continues to guide our work. From scattered blocks to a solid fortress, MedDRA safeguards patient safety. I hope we can all become happy and skilled MedDRA coding engineers. That's all for my presentation. Thank you very much. If any question, you can contact me via the email below. Thank you very much again.
Thank you, Elaine. Big thank you to you for that presentation. It addressed many common questions from our users, and I'm sure the audience today will find it valuable as a practical real-world description of coding conventions. So as Elaine mentioned, if you have any questions regarding her presentation, please contact her directly using the email provided. You can see it on your screen now, or you can reach out to the MSSO help desk and we'll pass on your questions to her. So I'll hand over to you now, Sohei. Thank you.
Thank you, Jane, and thank you, Elaine, for the great presentation. And now we have the pleasure of hearing from Jill Frady, who will share her experience with optimizing vaccine coding and classification in biotech. A quick introduction about Jill. Jill has 25 years of industry experience within both pharmaceutical and biotechnology companies. Today, she is a global manager in the medical coding department at MedDRA, currently overseeing immunology, oncology, cardiology, and rare disease studies as it pertains to exploring the mRNA technology and its potential for vaccines and treatments. At Moderna, Jill contributes to developing best practices, standards, and implementing technologies that enhance efficiency and accuracy across the organization. We will now be watching a recording of Jill's presentation, but we are lucky to have Jill join us live for a Q&A afterwards. So if you have any questions, please submit them to Slido. And now on to the presentation.
Hello. Today, I am talking about optimizing vaccine coding and classifications, and in addition, walking through a recent use case for our medical coding team. As part of the agenda, we would like to focus on why vaccine coding and classification matters, also where WHODrug plays a big part in our coding role, some challenges in current processes, not just with us, but hopefully across the industry. Also some optimization strategies, and then potentially some future opportunities. All right, diving in. Why vaccine coding and classification matters. As coders, we 100% know that accuracy drives data integrity. We run into vaccines with complex names, multiple variants on vaccines, and combination formulations that we need to analyze and make sure we have a consistent process for. Without standardized coding, the same vaccine from multiple sites could be coded differently. So accuracy is 100% needed. This always, unfortunately, causes inconsistencies in data sets, impacts medical reviews, and can create some reconciliation burdens. Unfortunately, it can also impact regulatory approvals. We all know that it is essential to have our coding as buttoned up as possible for regulatory submissions. Regulatory agencies expect the data to be harmonized, standardized coding, including WHODrug coding and ATC classifications. Incorrect and inconsistent coding can lead to additional queries from the regulatory agency and potentially submission delays, or what we all try to avoid, additional audits. Facilities, a vaccine coding classification also facilitates better safety and efficacy evaluations, which we all know is priority. With the coding, we can enable faster medical review, less back and forth with our sites, and move into a smooth database lock process at the end of a study. It's definitely critical in large vaccine studies with compressed timelines. As from an operational focus, supporting vaccine trials spanning multiple countries that have varied terminology is very important to support our vaccine coding and classification. Also, dictionary coding provides a common language across global sites, vendors, and supporting centralized data management. So from a medical coding team perspective, we do try to stay very on task. We also try to not be the one to have any issues or be a weak link in our chain. We all know inaccurate and inconsistent coding could possibly be the weak link. Always thinking through, is the data ready for review? Is it ready for inspection? Is there any potential for raising a red flag as far as coding goes? Where WHODrug comes in. WHODrug's role is imperative. We work in partnership. What it does provide is consistent classification. It helps us identify safety signals early, allows us very swift action to maximize our patient safety. Also, recommendation and decisions, swift and more clear communications and tracking. WHODrug also supports aggregate data at ATC level which enables cross-product comparisons. For vaccine studies, there are many times where we are doing a comparative study, looking at different types of influenza or COVID-19 vaccines. You run into inactivated vaccines, live attenuated vaccines, and then, of course, messenger RNA vaccines. WHODrug definitely provides support, and we could not do this without them. As we all know, whether you're a CRO or a sponsor, we're always going to run into challenges in coding, and now specifically with vaccine coding. Depends on the number of subjects. Is there a fast enrollment pace? Is it slow? Is there an increased burden on data review and reconciliation terms? Vaccines or terminology is always evolving, especially right now. Or do we have the most up-to-date dictionary for WHODrug? Or are we coding in an older dictionary? Maybe there's an inconsistent and manual coding approach. This can be when a sponsor works with a CRO, just make sure our conventions are aligned. And is there a lack of specialized knowledge among general coders? Is there a need for future upversioning? Do your conventions have gaps? And the list can go on and on. All right, just to give everyone an example, our coding team was working with a study. It was a very large phase 3 influenza vaccine study. It is recent. There have been a few changes since then, a lot of lessons learned. But in summary, there were initially over 50,000 patients that needed to be enrolled. It was a global study and extremely fast enrolling. We were also locked into an older dictionary version. In 1 month, we had about 14,000 ConMed terms. Month 2 months, 40,000 ConMed terms. And within 3 months, there were over 200,000 terms and 41,000 patients that had been enrolled in this global trial. There was a lot of data, and we are very grateful for our vendor partners in helping code. Breaking it down more into the initial vaccines, there were licensed products, investigational trial numbers, unknown brand name, spelling errors, but breaking it down, 32,000 vaccine terms, and even further, 19,000 influenza vaccine terms in 3 months that we needed to code and find some consistency in conventions. Here's just a few examples of what we received initially. Won't go through those, but we'll pop into the next screen. So at this point, we did notice there was a very large difference in how the sites were recording their vaccines. So medical data management, statistics, PV, and coding did start to be aware in our own areas that we needed to improve how the sites were recording and also potentially improve our process on coding. Optimization strategies. We did come to what was most important, and that was supporting the medical and the statistics vaccination analysis and ensuring PV monitoring purposes were improved for safety reasons. There was also talk or a decision to update CRF instructions on our ConMed section so the sites could have a little more direction. And then functional documents, we did look at improving or updating our coding conventions to create a standardized vaccine global guideline. Within coding, we needed to create and maintain a communication strategy with our internal and our external vendors because there was a lot of difference in how we were analyzing and making our classification coding choices. So we had one shot. There were a lot of queries with the help of data management that were sent out to the sites. And with a lot more direction, we needed brand names. We needed to know if it was unknown, any information that they could propose and improve the collection of the CONMED terms. And these are some of the outcomes that we got. But as you can see, these are very long. There is a lot of data, but we did know from a coding perspective that this was all we were going to be able to work with. There were not going to be additional queries going out to the sites. So from that end, we needed to leverage WHODrug. There were some WHODrug best practices in the document that we looked at. Was there anything for vaccines? We did find some umbrella coding options in Section 7, investigational drug section 7.2, and then when study protocol numbers were entered as a term in Section 7.2, and these were great references. We also reviewed standardized drug groupings user guide. The SDG option, there was a vaccine and there was a section with viral vaccine. Unfortunately, for the speed we were going at and what we needed, this was not of huge help, but it was definitely a great source of reference. And then we did run the couple of test data sets through WHODrug CODA. There was a lower certainty on the drug name, a lot of those matches, and then unfortunately a lot of uncoded no matches. This was something that we were hoping could help, but it was not at that time. All right, where we did end up as a coding team leveraging WHODrug. There are some great ATC level coding and search strategies that we could do. We settled in on also for some of the long terms, the influenza vaccines and other viral vaccines. These were very handy and we did use them frequently in our coding when we couldn't get a clear representation of what the site was entering. Frequent coding quality audits. This was constant. Our team, our wonderful vendor who was helping with our coding, we did find a few things that we needed to constantly monitor. One was in WHODrug, there was two options of influenza vaccines and influenza vaccine. If the site just wrote influenza vaccine, there was an active ingredient to it. It did get auto-coded, so we needed to go back and check those. Also, there is a term influenza, country of sales, from Korea. So if the site wrote influenza, it was a direct match. Software program, we did lean in heavily on our biostatistics team to help us identify CONMEDs that were coded differently, and then use the function of fuzzy matching, which would help us find word order differences or any spacing, hyphens, etc. Also, our automation AI assisted coding tools was from our CDMS, our coding system. So this was another help. All right, what we ended up with is we did create some specific coding guidelines for vaccines. Unfortunately, our database synonym hit rate decreased. So this increased our manual coding and review workload. But again, with the speed of the study, we do know that we needed to continue and just get the work done. Mandatory and improved coding. Investment in regular coding guidance was well accepted. Again, because we're working together with a vendor, the constant communication was imperative. Automated programming for listing reviews. We have reduced inconsistent codes, and then we maintained a dynamic coding dictionary. We're hopefully going to work with WHODrug more and look at some potential improvements and additions to WHODrug. All right, future opportunities. What we did think about is at the time of this study, our AI option was not as robust as it is now. We could work with some predictive coding models. There's also support from real-world evidence and HEOR group epidemiology and HEOR groups that we could use. Also, enhancement of our coding tools. There's different software that we could look at. And potentially we need to look for room of addition of some more investigational WHODrug options. Is there room, or would there be use for an investigational flu vaccine? It's only for example. But that is the end of our use case. We do know that everything turned out very well, and that every vaccine coded accurately in WHODrug and classified properly in ATC is a step closer to faster approval and protects the patient's safety. Thank you so much for your time. Have a great day.
A great thanks to Jill for her presentation. We've been very lucky this year to have such experienced presenters share their knowledge with us at user group meetings. I'm sure our audience appreciated how you highlighted the difficulties when it came to vaccine coding with this particular study, and also you sharing what worked to resolve some of those issues. Yes, now we're on to a live Q&A. So a word for our audience, please, if you have questions to Jill, submit them via Slido. While we're waiting for questions to come in, I will sort of steal some of your Q&A time and ask you some questions that I've had. You shared some of the optimization strategies you guys implemented at MedDRA. What would you say had the most impact?
Great question. So for us, the greatest impact was our staff, but we pulled in some very experienced coders and constant communication with our coding group. But from a WHODrug perspective, just having the structure, the ATC structure, and having a mass amount of options for us, specifically the influenza vaccines, it made it easier, but then it also gave another complexity level. And so I would say those two things: communication, and then having many options in WHODrug and being able to use it in the browsers.
And I remember you mentioned the tools that you looked at, the best practice we have for WHODrug.
Yes.
Again, coming from a very personal place, did you feel, what would you say was maybe missing from the best practices, maybe that you felt like could have helped you in this scenario, or coding for vaccines in general? I know we cover a few things, but there's always room for improvement.
No, again, great question. For us, we did not find a good deal of information about coding vaccines. So potentially having a little more guidance, or a section dedicated to vaccines. What was there was definitely a good support tool. And then another section that we did lean in on was investigational. We use the drugs, but the investigational drug section. And we would love to know maybe a little more guidance on what other companies do as far as coding, when there is more information than just investigational vaccine, and then possibly get some written guidance from WHODrug on what they recommend. Not the bottom line or not the final answer, but just recommendations.
And I bring this up because we are looking to revise or update our best practices document, and we're looking for, of course, contributors who have a lot of experience working with WHODrug, who could perhaps dedicate some time discussing these points with us. So,
perfect. Great question.
Yes. So if we can have someone or interested parties engaging in that, that would be great. I think we have a few comments and questions coming in. I think this is about the best practices. Could include more detail on attenuated live vaccines, etc. Yes, more specific types of vaccines. Yes, that's definitely something that we could cover. And I think we have a question for you, Jill. An operational question: should we plan for more QC time for larger trials than 10,000 terms? From your experience.
Yes, for our group, 100%. And I think this will change over time with additional tools or improvement to AI function. But where we were at when we were performing this trial, and as of right now, there was a need for additional time and additional resources. And that was not our intent, but because the influenza vaccines were being compared, it became very important to the other cross-functional teams that's where we needed to focus our time. We may not have done that had it not been a priority or been a sticking point, but for this study, we 100%, I can't even tell you how much time we spent, but possibly, hours per week with multiple coders and reviewers.
Oh, thank you for the question and
Thanks for the question.
And sharing your experience, Jill. I think maybe I will sneak in one more question to you. You gave very concrete examples of the kind of tricky, or let's say what we call unfortunate trade names in WHODrug for like influenza as a trade name or influenza vaccines being a trade name. How did you deal with those kind of situations? Did you have programming in place, or was it just review audits?
There was a lot of review, a lot of audits, but we did come up with conventions. And this was something that we had to approve within our coding department, but also had to be approved by the medical group, by the statistics group. And if there was a big issue with such as the influenza, we knew it was not a site that was in Korea. We did get permission to go back and ask the question. Can you add any information? If they just wrote influenza unknown, that was a little bit of a help, but conventions and working with, again, our cross-functional teams, and then lastly, a query if we were able to get more information. Thank you.
Yeah, thank you for the answer. And again, thank you, Jill, for joining us live today, and thank you to all those that engaged in the Q&A. We've dedicated our dedicated time for Q&A has run out, but if you have any more questions to Jill, please feel free to email them directly to her or to our WHODrug support so we can share it with Jill. And thank you again, Jill, and over to you, Jane, for our last presentation.
Wonderful. Thank you, Sohei. So the last presentation for today is about the use of MedDRA queries in the safety assessment of medications. And it's given by Evelyn Bassani and Natalia Menezes, who gave this in the Latin American user group meeting. We're very fortunate that both Evelyn and Natalia will be joining us live for Q&A after we've watched their recording. So let me tell you a bit about them. Evelyn is a pharmacist with postgraduate degrees in clinical pharmacology and project management. She's been working at Bayer for nearly 20 years, and during that time, she's held various roles in pharmacovigilance, including single case handling, quality, and compliance. For the last 4 years, Evelyn's transitioned into the position of medical dictionary expert within Bayer's clinical coding group. And Natalia is a medical doctor specialized in psychiatry with experience as a co-investigator in multiple clinical trials. Her professional background includes roles as a medical reviewer and global science liaison in pharmaceutical companies. Since 2018, she's been part of the Benefit Risk Management Department at Bayer, serving as a global safety lead for various products. So, without further ado, let's hear from Evelyn and Natalia, and then have the live Q&A after.
So, hello everyone. My name is Evelyn Bersani. I'm working at Bayer currently, and today we'll talk to you about the use of MedDRA queries in the safety assessment of medications. This presentation will have two parts. So in the first half of this presentation, I will provide you a high-level overview on how the medical coding team works at Bayer, including creation and maintenance of the medical term groupings. On the second half, my colleague Natalia, she will talk to you about how the benefit risk management team works with these MedDRA term groupings in the safety assessment of medications. At Bayer, the medical terminology is done in a centralized way by a global team. And here we ensure a high quality coding standards and practices throughout the organization. Our team is responsible for several different tasks, but today I want to highlight a few of them that involves directly the use of MedDRA and WHODrug dictionaries. The first one is a medical term coding process. This process involves the selection of the most appropriate code for a medical term. And here I'm talking about adverse events, medical history, and also codes for reported medications. Also part of this process is to ensure that the assigned codes are in line with the company's coding philosophy. And if not, then appropriate feedback and trainings will be provided. Another important activity that we do is the biannual update of MedDRA and WHODrug dictionaries. And here we need to ensure that all the systems, interfaces, documents, tools, basically anything related to medical coding are running with the latest version of the dictionaries, both dictionaries. Another activity that we do is the medical term maintenance and creation. And for this, I will talk a little bit more about in the next slides. As I just mentioned, for medical term coding, we work with MedDRA and WHODrug. And this is also true when we talk about queries, or as we call it internally, medical term groupings. A query or a grouping is essentially a tool that is used for safety data analysis. Here at Bayer, we work with two major groups. We work with MedDRA term groupings, and this consists of list of terms, mainly PT terms, that are referring to the same medical concept, and they are used in safety data to identify adverse events of interest. Whereas the drug groupings is a list of substances with one or more pharmacological properties in common. For example, pharmacokinetic properties, and they're mainly used in clinical studies to streamline safety assessment. When a grouping needs to be used for an assessment, our priority actually is to use the standardized queries that are provided by the MSSO or by the UMC. However, there are some situations where these standardized groupings are not sufficient for that specific data analysis. When this happens, this may happen, for example, when the standardized grouping does not have all the needed terms, or if they are considered too broad. In such scenarios, we from the medical coding team are asked to create a customized grouping, or also called a company-specific grouping for that specific data analysis. In the company, we have a few different types of groupings, but today I just want to bring here some examples of these groupings. So for MedDRA, we have one that is called Product Buyer MedDRA Queries, or PBMQs, and this consists in a list of PTs or HLTs or even an SMQ that are related to a specific medical concept, and it's usually created for a specific product. The other example that I bring here today is the product data sheets, or PDSs. The PDS is a list of adverse events that are listed in the reference safety information of the product. This type of grouping is used by pharmacovigilance mainly because it runs on the background of PV's database and supports the classification of a reported adverse event in relation to its listedness. For WHODrug, we have one grouping that is called Buyer Drug Groupings, or BDGs. When we talk about groupings for WHODrug, we only create them in very specific situations because it requires a high maintenance effort given the complexity of its content. Here, we do not consider only the single substance, but also the salts, the esters, and the different combinations with that substance. So a BDG will be created in the company if there is no suitable standard grouping available, or if a SDG is considered too broad and the company would like to have only the substances that are considered clinically relevant. And how do we create such customized groupings? So as I mentioned, for drug groupings, considering the complexity of such groupings, they are not created so often. On the contrary, for MedDRA, this is created quite frequently. And for this, we have an established process. The process itself, it's quite simple. So first, we need to receive a formal request from what I'm calling here a stakeholder. Our main stakeholder today is Pharmacovigilance Benefit Risk Management team. So when we receive a request from them, the first step will be to look into our system to see if there is any grouping available that can be used for that request, or more than one grouping that can be used for that request. If it turns out that there are no available groupings, then together with the requester, we will define the parameters to create a new grouping. These parameters consist of having a clear medical concept defined, of course, here also the content. So what are the PTs to be included? Are there going to be any HLTs or even another grouping, for example, an SMQ, of course, also as long as they are all related to that medical concept. We also establish timelines for each step of the process and so on. Once all of this is defined, then we create the grouping in the system and release them for use. Our responsibility here, when we talk about medical term groupings, does not stop at the creation of them, but also the maintenance. And the maintenance is to keep them up to date. And this can happen in two different occasions. On the first occasion, we are talking about the biennial upversioning of the dictionaries. So all the changes that happened in these dictionaries needs to be reflected in the groupings. And a second occasion where this can happen is what I'm calling here ad hoc changes. And this allows us to make adjustments to the grouping. It can be either correct and inconsistent that was identified, or even the content. So we can add, for example, a PT, or we can delete a grouping that was included in the grouping, and they are no longer needed for the data analysis. With this, I will hand over now to my colleague Natalia, and she will walk you through how they use these queries for safety assessment. Thank you.
Thank you, Evelyn. My name is Natalia Menezes. I'm a Global Safety Leader at Bayer, and I'll walk you through the role of Global Safety Leaders in our Benefit Risk Management team at Bayer. And our primary role is to ensure patient safety through continuous safety surveillance and benefit risk assessment of our products. Our main tasks consist of the preparation of safety documents such as the CCDS, PBIRs, RMPs, the management of safety-related communications with health authorities and other stakeholders, and the evaluation of safety signals from multiple data sources. And this last one is a very important task, and I would like to focus on that in this preparation. So what is a signal? Signal is any information arising from one or multiple sources which suggest a new potentially causal association or a new aspect of a known association between a product, an intervention, and an event, either adverse or beneficial, that warrants further investigation, further verification. And the signal management is a set of activities performed to determine whether there are new risks associated with medicinal product or whether known risks have changed. So we have a very established flow for the signal management process through signal detection, signal validation, assessment, recommendation for action, and exchange of information. And here we can see how relevant the MedDRA groupings are for the safety, the signal assessment. The MedDRA facilitates the signal, the systematic identification and analysis of signal by grouping medically related terms into clinical categories. So I will walk you through some practical examples and how those signals can be triggered. In this first example, you can see that a local sales rep was informed by a physician that 4 of his patients have presented gastrointestinal events. And those events and endoscopy has reviewed gastric ulceration in those patients. So we have used the MedDRA grouping SMQ gastrointestinal ulceration to investigate the cases. And also we have reviewed the available literature, and the signal was confirmed upon that investigation. So we have also implemented routine risk minimization measures, such as the inclusion of gastrointestinal ulceration into the company core data sheet sections 4.8 undesirable effects. And we have continued the routine PV activities, such as case monitoring, follow-up analysis of the signal. In our next example, you can see that sometimes health authorities can request some specific MedDRA groupings and specific investigations, and that was the case. So this health authority has requested various MHs to investigate potential nephrotoxicity associated with specific drug class and recommended the inclusion of specific MedDRA terms. So the signal was confirmed. You can see on your right that we have also added some groupings that were considered relevant for this investigation. And upon confirmation of the signal, we have implemented under section 4.2 a dosing recommendation for high-risk patients, and under section 4.4 a specific warning regarding the risk of nephrotoxicity. Additionally, we have also initiated a post-authorization safety study to investigate renal outcomes. And in my next example, I bring you a signal that was triggered by the review of a systematic, published systematic review, in which it was identified a higher reporting rate of severe hypersensitivity reactions, particularly among patients predisposed to allergic reactions. For that scenario, we have used the PBMQ immediate type of hypersensitivity reaction, which was specifically tailored for the drug class, and the signal was confirmed. We have also implemented the minimization measures, such as contraindication for patients with history of severe hypersensitivity reactions to the active substance or its excipients. And we also implemented a specialized follow-up questionnaire. So what we would really like to convey is that MedDRA groupings enables consistent data interpretation, evaluation of safety signals. It facilitates the collection and conversion of medical information into standardized medical terminology. It ensures regulatory compliance, enhanced communications. So this standardized approach provided by MedDRA groupings is fundamental for regulatory compliance and effective global PV practice. Thank you very much.
That's great. Well, thank you, Evelyn and Natalia, for that presentation. Very, very, very interesting, that one. I hope everyone enjoyed that presentation as much as I did. It really was a great look into how MedDRA queries are systematically created within a company and managed for use in the signal detection and safety assessment. So while we're just waiting for our audience to type their questions in, remember you can do this live only if you're out there in the audience and you've got questions for Evelyn and Natalia, type them in. Meanwhile, I'll ask you a couple of my questions. So I'm interested in your third example, Natalia, with the hypersensitivity, and just why did you choose to use that one? You created one, and I know we've got a couple of SMQs around the hypersensitivity, anaphylactic reaction, and so I'm interested in, you mentioned it was drug specific. So can you tell us a bit more about why you created it and whether it stayed drug specific or whether you added it to your repository that could be used by other products?
Sure, thank you, Jane. Yes, that's a very good question, because we always need to keep in mind that when you create a PPMQ, you're creating that for a specific product and for a specific analysis, right? So you do have a very particular interest to be addressed, and SMQs are great as they are, but in that particular scenario, we were assessing allergic reactions which comprise broad manifestations. So we do have in that scenarios, we wanted not only to capture skin reactions, for instance, but all the range of respiratory system reactions that were affected, cardiovascular reactions that are affected by allergic reactions. And for that purpose, we have combined two broad SMQs, anaphylactic reactions, just to give you an example, and angioedema. And we have also included individual PTs to ensure that we had higher sensitivity for that specific analysis. And we continuously, we have used that PPMQ for that particular class of drugs.
Oh, I see. It was combining a couple of for your purpose. That's interesting. Thank you. Thank you. And did you use it in other drug? It was just used for that drug then, was it? That one? Yes.
For a class.
For the class.
A class of that are part of our portfolio that are quite related and an established class effect for this class.
Yeah. You mentioned that it's quite common to create these corporate customized queries, as I would call them. So how many do you have? Do you know offhand how many you do have in your repository?
Yes. So if we are talking about only the customized ones, including all the different types that we have, currently we have around 600 groupings.
Oh, that's quite a lot, isn't it?
Yes.
Wow, that's some maintenance then for your team. Interesting, interesting. And who makes the decision? So you said that the stakeholder will request come in and you check your portfolio, your repository to see if there is something, and then ultimately who would make the final decision then to make one?
Yeah, so this final decision, as Evelyn has mentioned, can be requested by the GSL, and mainly it is requested by the GSL, and the decision to utilize that particular one is also handled by the GSL, who, along with the safety management team, so a cross-functional team, we can decide where and how to use it, as well as the need to create one. You know, if Evelyn would like to add something.
No, yeah, actually, this decision of a grouping needs to be created is really coming from the functions. And from the medical coding perspective, we are supporting them by looking into our system to see if there's something that they can already use, or maybe a combination of groupings that can be used, and then we give them this kind of support. But the decision of really creating is coming from the functions. We do not proactively create something.
I see. Interesting. It's very good, and yes, very impressive. So of your 600, have you sent some in to propose SMQs from those, or did they stay have they all stayed internal?
They stayed internal. At least from our perspective, we don't really see how this would be valuable to the MSSO, because these are more related to requests that are coming directly to our company. So, yeah. So we did it. Yeah.
Interesting. So I see we're getting the questions coming through now. So here's one for you from our audience. Are there any practical examples of using your detecting safety signals during clinical development using either the SMQs or your customized queries?
Yeah, that's a good question. We do have those safety analyses where we use MedDRA tools all the time. Those are important throughout the development of the drug. So since clinical development, I mean, each GSL has its particular safety topics to be analyzed. I could cite some. As I have mentioned, allergic reactions are a very common one, but sometimes we do want to assess early on kidney impairment or potential liver impairment when we think about early clinical development, right? So when you're assessing PK and pharmacokinetics and other. So each product, I'll say, have its own safety topics to be further investigating. That depends on the characteristics of the product and also on the population that has been under investigation. So there are a couple of elements that will determine what kind of safety topics will be assessed.
Thank you. Thank you. Very interesting. It is a very, very interesting topic and great presentation. So let me just have a look. I'm not seeing any other. Oh, one more's just popped in. I think we'll do one. I'm conscious of time and I know we're running a couple of minutes over schedule, but let me just try to read this one as you're both here with us to share. Do you perform signal detection analysis at various levels of the MedDRA hierarchy using perhaps some kind of tree-based scanning algorithm, or is that analysis targeted to just specific lowest level term or preferred term? I'll give you a moment to just digest that.
Yeah, I think that what I understand from this question, please weigh in if you meant something different. So we not only do use preferred terms, but the groupings, the MedDRA hierarchies groupings are very helpful and they are commonly used because we do need to have hierarchies whenever you have a safety topic that using PTs, individual PTs, might not be the most efficient way to do that. So we do have a higher hierarchy. Yeah, I would say that this is very important and we do use that.
Thank you. Follow-up question, I think. Thank you for that one. Is there a threshold percentage to call it a signal? I think that's come from one of our earlier inquiries. Is there a threshold that you call it a signal? That's a bit more of a PV question there. So.
Yeah, so it's a very interesting topic and complex when it comes to detection. I'll try to give you a very concise and in a nutshell. To call it a confirmed signal, you have multiple aspects. So not only you don't have a determined predefined percentage because you have so many variables to be assessed. You have your product with its own characteristics, the population. Each specific patient has their underlying conditions that need to be taken into account, right? So you do have confounding factors in each safety signal that you need to exclude. You might have suspect drugs, for instance, just trying to give you a sense of how many variables. That's why we don't have a specific number to confirm or refute a signal, because what we need to do is essentially a medical activity, a medical assessment, very thorough. We need good data, and we don't have a specific threshold, but we do have variables that need to be taken into account for that.
Thank you very much, Natalia. Well, we've got a couple of other questions, but I'm aware that we're running out of time and it's getting quite late for some people in the world. So I've asked a couple of people to, they say, if you've asked a question, write into us, give us your email address. I'll pick that up and we'll pass on the questions to you if that's okay. But thank you both so much for coming and joining us today to answer these questions live. We could be here all evening discussing it. So thank you very much. But
Thank you.
very big thank you. So Sohei, I think in the interest of time, it is now time for us to wrap up.
Yes, it's already time. Jane and I hope that everybody enjoyed the webcast today, and we are very interested to hear your opinions. After the session, there will be a survey, so please share your honest opinions on what worked well and what we could improve for future events.
Yes, absolutely. I couldn't agree with you more, Sohei. So before you all go, a quick reminder about the slide handouts as well. If you'd like to download the handouts now, you can find them under the resources. If you look at the black bar at the bottom, the toolbar, they'll also be available in the UMC website, user group libraries, and MSSO website event page, along with the recording of the session. But give us a few days to just check the recording and process it before you look for that. And then, since it's a very commonly asked question, please note we will not be issuing attendance certificates for this session today.
Yes, and if you have any further questions for the presenters, or if you have any general questions or comments about WHODrug or the event, you are always welcome to contact our dedicated WHODrug support team. And similarly, for questions and comments on MedDRA or for the MSSO presenters, please reach out to MSSO Help Desk.
So it just remains for us to say thank you to Patrick, Brian, Elaine, Evelyn, and Natalia.
And thank you once again to Peter, Emanuele, and Jill for your time and sharing your knowledge with the WHODrug and MedDRA community today.
Absolutely. And thank you to you, all of you in the audience, for your attention, your active participation, and the thoughtful questions. And just before we go, I'd also like to acknowledge Katia and the rest of the UMC team who have been working diligently there behind the scenes to coordinate with our speakers, support the facilitation of today's webcast. So thank you all for your excellent work.
Right. Goodbye, everyone, and enjoy the rest of your December celebrations. And we will now close this webcast. Bye.
Thank you. Bye, everyone. Bye-bye.